Can a patient get genetic testing even if their doctor doesn't recommend it?
Yes, so absolutely. I know at our in our clinic, we do have self-referrals as well. So if you're just curious about your family history, you might not meet the national criteria. We talk about that in the session. And oftentimes with many of the labs, is typically an option to pursue genetic testing through self-pay, where we don't typically go through insurance in that case, since insurance is unlikely to cover it. And oftentimes with some of these labs, the self-pay price can be about $250.
Okay. And is there a difference in the reliability whether genetic testing is done on blood or saliva?
Great question. So from a reliability standpoint or accuracy standpoint, there's no difference. Really, it just kind of comes down to sometimes we might see that the saliva sample can fail a little bit more, but that has to do probably more just with human error than anything else, from the standpoint of sometimes people don't fill to the line or include their bubbles in the line of the saliva tube. As you can imagine, a saliva sample is a little bit more dilute with their cells. So we typically need a little bit more sample with that volume wise, whereas with the blood draw, it's typically a pretty standard thing that you're just getting your blood drawn with. But we do either samples, and typically with a lot of these labs, even if your saliva sample fails or doesn't meet their metrics that the lab has, then they will just send you a new saliva kit and we will just kind of go at it again. Typically it works.
Great. So can you explain a little bit about your approach for genetic testing within a family? So there was a question, patient's sister was tested and she was negative. Does the sister still need to be testing? So how do we approach it? Who do we test first, and how do we make those decisions subsequently in families?
That's an excellent question. So typically what our testing approach is, or we typically talk about the concept of the most informative member of the family to get genetic testing. So in a family, so actually if we can go back to the slide that had the little family tree on it, that would probably be helpful in illustrating the answer to this. So just as an example here, the arrow is pointing to a patient, the female, who is not shaded in. She does not have a cancer diagnosis. So let's say that I was seeing someone like this in the clinic. Ideally, we would want to have the individuals in the family who had the quote unquote cancer of concern, which in this case is breast and ovarian cancer, get genetic testing first. Because if we tested the lady who does not have a cancer diagnosis, and if she tests negative, meaning we did not find any harmful mutations, we don't know that she tested negative because the cancer in the family is not because of a hereditary change that we can identify, or she just did not inherit the gene mutation. Having a genetic mutation in the family does not guarantee that you're going to inherit it. Typically, for the way a lot of these genes work, there's a 50-50 chance that you inherit it. And so that's why we would want to start off with genetic testing for someone who has the cancer of concern. And then depending on the family history, we may or may not recommend testing for other family members afterwards.
So if a patient's mother had breast cancer and that mother has two daughters, one of the daughters is tested and was negative, does the other daughter need to be tested?
Yes, I mean, assuming if the mother is unable to get testing, then yes, we can test the other sister as well. Of course, if the mother herself who has the breast cancer is available for testing, might be reasonable to go ahead and do testing for her first, since those results could then help determine whether or not we need to do testing for the other daughter.
Okay. And so I want to give a shout out to Mel Neopold, who is on, I see. Thank you, Mel, for joining. She has her family history. She has 3 generations of breast cancer, as she shared with us last year. Her mother's expanded gene panel testing came back negative. Do you anticipate that more genes will be sequenced in the future that will explain this family history?
That's an excellent question. So one of the limitations we always mention with genetic testing is that we know that we're still learning. So there could very well be genes that we learn about in the future that could explain the family history of cancer in a lot of these families where we don't still have an explanation from a genetic standpoint, but where we can still see that something still looks like it might be hereditary. And that's part of the reason why when it comes to making recommendations for screening, we don't just make them based off of a genetic test result. I like to explain it that our physicians are typically looking not just at your genetic test results, but they're also looking at your family history and personal history to help guide your care in terms of what recommendations they're making for screening.
Absolutely, and that's really what we're trying to do in the BPREP program. As Fatima mentioned earlier in her talk, most cancer is in fact sporadic. It's not hereditary or it's not familial, and so we really are trying to understand all of the different risk factors that go into a woman's profile for her chance of developing cancer. Just to sum up, a couple other questions. So if a woman does carry an inherited mutation in BRCA1 or BRCA2, their lifetime breast cancer risk is estimated to be between 50 and 80%. And that is a wide range because there are differences between BRCA1 and BRCA2, and there are differences again with the penetrance of these mutations in different families. So if you remember the boxes with the 100 gray women that I showed you earlier, 12 of those women out of 100, that would be average breast cancer risk. When we talked about the high risk lesions, I said that it could be anywhere up to 15 to 20 or 25 of those gray women, those 100 gray women might develop breast cancer. And then when we talk about the hereditary cancers, particularly the BRCA1 and BRCA2 mutations, now we're getting up to where 50 or 60 or 70 of those gray women are now turning pink. That is their breast cancer risk. So we can see that all these risks are all different. They carry different implications and again, different options for management depending on the level of risk. If a patient has breast cancer, has genetic testing, and that testing is negative, then her children do not need to have genetic testing. That would be considered an informative test. So wonderful. So let's move on. Thank you, Fatima. So our next